Thank you very much. I've got really something to say both about innovation and around economics, so it's just as well that these two sponsoring organisations are sponsoring the event. I want to really talk about what I think is a profoundly radical challenge to the nature of our health services and a bit of a solution to that challenge. And I want to talk about it in terms of what is a new business model for healthcare, and try and demonstrate that's a profound challenge to the old business model. So I think there is a generally quite a large case going around the world. Most health systems will say we have a profound challenge now and into the future. And then they'll say, but actually it's a bit too profound to do much about, so what we're going to do is fiddle. And honestly, that is almost a universal thing that's going on, because actually the profundity of the challenge does need very, very radical thinking. So I'll talk a little bit about that, and then talk about what the economics of that is. And the second half of what I've got to say is to run through a specific, not a large example, but an example of 6 different pilots in England organised by the innovation organisation Nesta, the National Endowment for Science, Technology and the Arts, about what we referred to as people-powered health. But I want to start with what the compelling case for change is. The demand for healthcare, certainly in my country, is going to go up by about 3% a year in the next 10 years. And that's mainly because people like me are going to get older. And as we get older, we will get long-term conditions. And so most of the demand for healthcare that's going to come down the line is demand for long-term conditions. And that will either be very expensively dealt with or will be very cheaply dealt with. And that's the issue that health services need to confront. And there will probably not be any increase in resources. Over a 10-year period then, that's probably an increase in demand of about 35% and no increase in resource. That's a serious challenge, and I think needs a new business model. What we'll need to do over that period of time is produce significantly better health outcomes for roughly the same resource. And that in other industries, going on all around us, in other industrial models, demands a new form of business model. Most leaderships of most health systems follow the story to this far and say, yes, that's true. But actually, in most health systems, the old business model is actually the thing that encapsulates most of our thinking. We think within that model. And therefore, whilst we talk about a new business model, it is actually quite alien and quite challenging to the nature of the old business model. This, as I'll go on to say, isn't going to be over the next decade a pretty sight, because there will contain conflict between the old and the new, as it has done in every other industry. As it does, the old doesn't like the new has to take on the old, and there will be conflict. And so this is a story of not a smooth transformation, but a story, as in every other industry, of a conflict between the old and the new. The key part of my economic argument is within developed countries' healthcare systems, value comes from a limited range of sources. The value primarily comes from medical staff, their kit and drugs. And people who are ill come up against those value creators, and value is created in that interaction. The patient is seen, it's an awful phrase, but it feels like that, as a sponge on that value. I'm ill, I go and see a doctor, the doctor gives me some value, I walk away in some way better, having had that value from that doctor. I take some drugs, I get better. So I do nothing except sponge on that value. And the problem for the future is, to use a very English phrase, there's going to be many more sponges. There's going to be many more of us who will be demanding more of that value. Over the next decade, therefore, within the old business model, we'll need more value creators to meet more ill people. But we can do things that will transform bits of that value. Nurses can replace doctors. All sorts of things can be done within those value creators. But I don't believe it'll be enough to construct a third more value with the same amount of resource. So we need to find, in a new business model, new value creators. And in most other industries, that has been what new business models do. They uncover areas of interaction which previously have not been seen as value creators and say that will create us some value. And in many industries, work, the creation of value, which used to traditionally be done by staff, is now done by customers as well. We are used to being value creators in the modern world in a whole range of industries that we weren't in the previous world. We become co-producers of value. And around us as co-producers of value, the industry has changed radically. The retail industry now, certainly in my country and in your country, depends upon me as a consumer to create a lot of value. I go into the shops, there used to be a range of people between me and the produce called shop assistants. I didn't like that, actually. I like to get my hands on what I'm buying, right? But in doing that, I personally sacked quite a range of shop assistants because I'm now doing their job. They used to do the barcoding. I now do that as well. I personally make a lot of money for the supermarkets by creating that value. I've changed the nature of the value creation because up till then, the retail trade used to see customers as a real pain. They'd come in, they'd get in the way, they'd want all sorts of different things. Now, we are seen as an asset. And that seems to be a crucial word in this process of change. How do we create new assets from things that up till now have been seen as simply, to use that word, sponges of value? Certainly in all of these industries, in retail banking and in retail, there has been a sharp conflict between the old and the new. And equally importantly, and this is I really want to underline this point in talking about health services, but equally about all these other industries, this is not to say that customers are the only producers of value. That is not what I'm saying in the retail trade, in retail banking, or in the health service. What I am saying is that actually we co-produce that value. And if you look at what goes on in modern retail, there is an intensely powerful logistical enterprise going on around me so that I can then reach into a shelf and get something off that shelf. If that logistics isn't working, I reach into the shelf, there's nothing there, I co-produce nothing. So the point I'm going to be making about the co-production of health is that actually it's not to say the current value creators are not a crucial part of that, but they need to behave in a very different way so that we co-produce that health. What is it that's going to be surrounding me as a patient with my long-term conditions over the next 20 years, which is going to allow me, encourage me, entice me into being a co-producer of value? The problem we have got is that by and large, in the existing model of medicine and healthcare, we as patients have been excluded as value creators. We've not been allowed to play much of a role, even if we wanted to. So this idea that I can now become a value creator is in fact, in some ways, very straightforward, very simple, but within most medical models is a very profound challenge. And in diffusing this idea across healthcare systems, that challenge can be one of the major reasons why it stumbles. Because actually, again, I've done lots of meetings around this where doctors will say, I've studied for 12 years and now you're saying you as a patient can do what I can do. No, not what's being said, but actually that's what's being heard. So if we are saying patients are co-producers of value, it's different from saying we're the only producer of value. I know I'm hammering on that point, but honestly, in every discussion I've had, however often I say that, what gets heard is patients will look after themselves. That's not the case. So the issue that is transforming our health services is variously called long-term conditions and non-communicable diseases. The trick is in the label long-term conditions. You have them for a long time. And because you have them for a long time, you gain some semblance of knowledge about the interaction between this thing and you. I've started to get rheumatism and arthritis. My dad had it. I knew I was going to get it. But actually, my knowledge about this disease is about my body interacting with that disease. And over the year that I've had it, I've learned a lot about that. Most of the doctors that are trying to treat me don't recognize that knowledge. I reckon I've got another 20 years of learning about that knowledge. That, crucial word, is an asset. Is it seen as an asset? Probably not. So every time I go and see my doctor about my rheumatism, which actually isn't very often because I don't think the interaction is at all worthwhile for me. Every time I don't go and see my doctor about my rheumatism, it's actually he and she is throwing away the asset that is me with a long-term condition. 70% of the money in the National Health Service is spent on long-term conditions. So this is not a trivial little issue. It is the issue which will bust our health services, and we are throwing away the asset that the patient has because it's a long-term disease. The new value chain needs to be created by exploiting this form of value creation and placing it as a part of the value chain. Now, all of us in healthcare systems are recognizing that the major organizational problem we have in healthcare is that we've constructed an episodic healthcare system for what is essentially now one that needs long-term patient pathways. And so if you are an 85-year-old with 3 long-term conditions, it's quite likely over a month you will see 16 different professionals. You need an Excel spreadsheet to keep on top of that. And it's very hard. And each of them are individually coming in relationship to their organisation and their timetable and their needs and not yours. So the difficulty then of you adding value to that episodic care is really hard because you're actually having to think through very different things that are coming at you all the time. So a part of the process that I'm talking about here is not just adding the value from patients, but actually how do we add that in an integrated care pathway where people are allowed and encouraged to be part of that value chain. So the essence of what I'm talking about is around long-term conditions. The reason that is so important is they're a very large part of what's bankrupting our health service. And equally, the essence is that because you have them for a long time, you, your friends and family in your community have some knowledge about that, and that knowledge is an asset that can be used. Interestingly, this is not just around long-term conditions, but in talking to other medics around this issue, there are very different examples of how other parts of the medical profession can see this as a major part. Obstetricians and gynecologists have seen this, the co-production of babies. It's a fairly obvious thing that actually the mother is pretty integrally involved in that. And if we actually construct a maternity pathway where they're not, it's a disaster. If we construct a maternity pathway where we recognise that every moment that we can invest in that mother will make for a better baby and therefore a healthier child and a healthier mother, then the co-production of maternity is a fairly obvious part of it. This is an even more interesting example that comes from a discussion I had with the Royal College of Anaesthetists, because I went around all the Royal Colleges talking about this. And the truth is, when I got to the anaesthetists, I thought, well, what on earth is co-production here, eh? Because they're out of it most of the time, right? What's the discussion that goes on between an anaesthetist and a patient? And the guy from the Royal College said, no, you got this completely wrong. My members would love to ring up everybody that's having an operation 2 weeks before they have the operation. We'd like to talk to them about diet, and we'd like to talk to them about exercise, and we'd like to co-produce anaesthesia. Now, that is interesting. If that doctor can see that, and it will change the nature of anaesthesia and change the nature of recovery and change the length of stay. The co-production of anaesthesia is a real, but actually that's a part of what that profession sees. So there is, as we discuss this, as I said, some sort of battle between the old and the new. There has been in every other industry. When supermarkets being rolled out in England, there was a very tough fight back from sort of mom and pop stores that virtually was saying, we can't expect older customers to play this active role. They'll starve and it'll be your fault. Now, that's what's going to happen in healthcare, right? If you think patients are going to be doing this, it won't work, old people will die, it'll be your fault. That's happening. This is the nature of the discussion that takes place between old and new models. And how do we engage in that has to be a part of this process of diffusing this sort of innovation. So what does this mean? My argument is not simply about prevention. My argument is about the 15 million people in my society with long-term conditions. They're the people that we know are going to cost us the money and we know is going to bust the system. The interesting thing about these 15 million people is if you have a long-term condition, you have it all the time, and you are self-managing. Now, sometimes the health service thinks it's introducing self-management to the patient. No, the patient manages their self. There's no one else around most of the time. That's what they do. The problem is they don't do it very well, but they do self-manage. And this is one of these interesting stats that when you sit down and work it out is a very crucial stat for the productivity of the health services. Waking hours over the year, you're awake for about 5,800 hours. That's the amount of time you are self-managing. Amount of time you see a doctor, 3 or 4 hours. Amount of time you see a nurse, 5 or 6 hours. Very important hours. If you're really quite ill, it might add up to 100 over a year. But actually, it's 100 and not 5,800. What is the most important statistic? If you increase the productivity of self-management by 5%, you've transformed the productivity of a health service. If you increase the productivity of the NHS bits by 5%, you've done some decent work, but you've not transformed the equation of the health service. And the obviously crucial thing is how do we use the 5 hours, the 10 hours, the 100 hours to multiply the productivity and the efficacy of the 5,800 hours? What is it that we can do in those precious professional times to actually ensure we are leaving patients with more capacity to self-manage, rather than occasionally what we can do is take away their capacity to self-manage and say, you're completely hopeless, wait till you come back and see me and we'll talk about it in 6 months' time. How do we generate a much greater capacity in the hours we've got? And that is, as we'll see later on, a change in the nature of the consultation process. We are talking about how a healthcare system searches out new assets. One of the really interesting things, this will happen in your healthcare system, it certainly happens in mine, is that we know, intellectually we know, that carers are this massive resource. But we very rarely interact with them as the resource that if they walked away one day would bankrupt our health and social care system. We don't interact with them as absolutely essential to what we're doing. They're sort of a hobby that comes on the end of a medical pathway rather than being the essence of it. So patients, their carers, their families and their communities have a set of powerful assets which are answers to a patient pathway, because that patient pathway isn't just a clinical issue. Long-term conditions are a combination of clinical and social, and therefore they need a combination of clinical and social inputs to do something about them. This is then a concrete example of 6 different pilots in England where we developed these ideas. Interestingly, Nesta, as I say, is an innovation organisation. Look on their website. I've got the URLs for all of this at the end of the slide pack. But what we wanted was to put some money into a number of very small examples of where co-production of health was taking place. And so we advertised, 70 people applied, 70 organisations applied as part of the National Health Service, which were doing very different but actually small but significant things. One of the And these were, in terms of Alberta Innovates, these were innovations. These were all little innovations. And you'll know in your health service, there are hundreds and thousands of little innovations going on. What we said, though, is that in constructing these innovations, in order to be selected to be part of the pilots, you needed to understand that diffusion was the issue as well as having the innovation. That actually our healthcare systems have got hundreds of small innovations that, again, are sort of people's hobbies, but don't sweep through the healthcare system and change it. So the problematic that we were testing with people-powered health wasn't just, let's look at the innovations, but what is the scaling mechanism for these innovations in a socialized medicine system? What are the things that can help these run through a system? So the products we've got at the end of this bit of the talk are 3 systemic sets of products and 6 that are referred to as mechanics, that are how do people do the co-production in various bits of the health service. But what was crucial then is the system changes we were talking about, as well as the particular examples. The 2 in mental health care, one of the really interesting things about mental health in my country, again, I don't know about here, but it's been quite a shock in a way, is that when you get into mental health and you look at what's going on, there is, in parts of the UK over the last 18 months or so, various mental health organisations have created something they refer to as recovery colleges, because this is an odd idea that you would recover. Mental health patients in one of these areas, a place called Stockport in the northwest, refer to mental health services as service land. Service land is quite hard to get into and impossible to get out of, because that's, once you're in it, you're sort of in it. So the notion of an outcome and recovering is something which actually these pilots were putting into operation. So these were the 6 areas that they did it in. And the problem, as I said, was we have got, and I suspect you have got, aspects of patient-centred healthcare going on, but they operate as medics' hobbies in a way. This is something we're really interested in, and we do here, but actually virtually nobody else does it. And we've got these dotted all around the place. And we said there needed to be some form of systemic way of building these. And these were 3 different, we've got 3 different products which explain what that is. The first is a business case. And it's very interesting to go through. This is a general business case of most of the work that's been done across the developed world around co-production of health. And the median amount of money saved is about 7%. However, lots of people have lots of examples of no money being saved at all. And the reason for that is what they didn't do, and what health services are prone not to do, is structure and stratify the patient group you're working with. So if you say we're going to deal with every person with diabetes, generally where you start when you do that work is people who've just been diagnosed with diabetes. It's sort of the holy moment in a way in healthcare, is the moment you've been diagnosed, and so we'll change the way in which we work with you at that moment. Really good, doesn't save any money for about 15 years. Because actually, you don't start costing a lot of money until the complications set in at some stage down the line. So the argument we are making in the business case is you need to be ruthlessly stratified in how you're approaching this. And different groups of the population with long-term diseases have got different sets of assets to be worked with at different times. If you're dealing with people over the age of 90 with 3 long-term conditions, they will have a set of assets, but are entirely different from dealing with me at 65 and what are the assets that I've got and how can my assets be. We need to stratify the way in which we do this and deal with very different groups of populations and recognise their different assets in different ways. If the problem is, and our problem over the next 2 winters in England is going to be large numbers of people with complications in their long-term diseases, going in with exacerbations into not just the emergency rooms, but into emergency beds for 10 or 20 days a year. That's our system-breaking problem over the next 2 winters, then let's concentrate on that group of people. Let's concentrate then on the people, let's do the co-production at the sickest end, because that's where the problem is. And that's where the evidence is, if you surround that person with enough capacity to add their capacity to it, actually persons with long-term conditions with an exacerbation do not want to go to hospital. When you ask them, why do you end up in hospital, it's because it's the only place that feels safe. We have failed to create the home as a place of safety for high acuity patients. And because of that failure, people go to the most expensive place, which is the only place of safety we've created. In most of the healthcare systems we've created, we've done something really quite bad and created the only place of safety being a place that us within the healthcare system know actually isn't safe. The last place you want to go if you're sick is a hospital. Right? We know that, but actually ordinary folk think that's the place of safety. What a mess, right? Whereas actually what we should be doing is construct, what we're going to have to do over the next 10 years is to create the home as a location where high acuity can be dealt with safely. And to do that, we need to look around the home, look around the environment in the home, look around family, friends, and communities and say, what assets can be used to make that home a place of safety? And in making that home a place of safety, we are co-producing safety, rather than actually simply saying the only place safety can be is in. This is, this over the next 2 winters is the crunch moment for my health service, is actually, it will go in the hearts and minds of very frightened old ladies and old men about whether they go to hospital or don't go to hospital. So stratification becomes, we should be in a position, if we've stratified the people we're working with, to say we're dealing with 1,500 people who are at medium risk or at high risk, and last year had this amount of money spent upon them. And next year, if we diminish that, we'll have less amount of money spent upon them by having the home as a place of safety. We know actually how to do most of those things. What we're not doing is putting that into a patient pathway, which in the end ends up with people not going into hospital. So savings can only happen if we're constructing in some way an economics part of this, which goes from the home into the emergency bed and out again. We need to be able to, in my country, we're calling this working out the costing of a year of care. And the year of care for people who are have high need is very different from a year of care that people have middle need, have low needs. But actually the year of care, what did it cost last year to look after me, to look after someone with high needs? And then how can we rework that money has to be a part of this change. If we are just looking at co-production as another fragment of healthcare, then we're not actually doing radical change. So these were the sorts of things we thought was necessary if you're going to have systemic change. We needed, as I said, some form of financial incentive. We have a very sharp commissioner purchaser-provider split in the UK. I'm not saying this is a necessary part of this, but you need some form of financial incentive. At the moment, the financial incentives take people into hospital, which is not the place we want them to be. You need financial incentives which work against that. And these are not difficult. They take some computation, but they're not difficult. There's about a dozen places around the UK that are working out a year of care for frail elderly, for not so frail elderly, for people with diabetes. We're doing that work. We must recognise, as a part of our system, and I think this is politically the most difficult, that actually we're not going to get innovation pulled into the system if we continue to subsidise failing parts of the system. I'm on a board of the quality control organisation in England called the Care Quality Commission. By about the end of next year, we'll have 40 hospitals in the UK that have got real problems, that are both clinical and financial. And at the moment, a lot of money goes into propping up those institutions. In other industries, that wouldn't happen. How do we find a life for those institutions? Because actually, the people need those institutions, but they don't necessarily need them full of inpatient beds. They need them to be really good long-term condition centres. How are we doing that? How are we changing the business model of small district general hospitals? Big problem for your country, enormous problem for my country as well. We need to mobilise clinical leadership. What was interesting, my example of the Royal College of Anaesthetists is both fun but real. it's been interesting going around talking about this to find that there are, in almost every specialty, clinicians that really get this. And there's others in the same specialty that really don't get it. And we need to mobilize a clinician-to-clinician discussion here. Because when you hear that happening, it's really quite interesting. One of the pilots was in pain management. Pain is an intensely co-produced thing. Pain relief is intensely co-production. It's not just a drug, it's not just mental health. You know, all those hours of pain during the day, you are co-producing how you deal with that pain. And hearing a pain specialist who developed with her patients a group consultation exercise where she'd been saying things to these individual patients for several months and not being heard, when the patients said it to each other, they thought, oh, they said to the doctor, why haven't you told me this? And the doctor said, I've been telling it to you every month, but actually you've not heard it. So hearing her talk to her fellow colleagues about pain management and group consultation is a really different conversation. If I say it, no one will listen to a word. So it's finding medical leadership. And this is a very important point, this fourth point here. And without this, I would be very pessimistic about anything much happening. The major patient groups in my country have, that's cancer care, heart foundation, lung, diabetes, the 10 major patient groups and the old persons group, Age UK, have come together into a group just simply called the Richmond Group. And I've got the URL at the end about their work. And they are passionate advocates for both integrated care and for the co-production of care. If you go on the Macmillan's website, Macmillan's is a cancer organisation, you go on their website, you'll see nothing but an argument for the co-production of health after you've had your cancer. The necessity of you playing an active role in that. And if the doctor says it's my role and not yours, what Macmillan says is that's dangerous. Because actually you've got to be playing your role in that. So what we've got is very powerful national patient groups that are looking at this. And honestly, in every other form of innovation, it's the consumers that pull that change into organisations. We've got that possibility with progressive patient groups that are critical of our current business model. But we need to find a way of enabling those customers, those patients, to actually do that pulling. One of the parts of this that I'll come to later on is actually that you're going to need a different contract between the doctor and the patient, a different care planning mechanism. And Richmond Group and I are playing around with, wouldn't it be interesting if on the 1st of September next year, every patient from those groups, about 10 million, was to start to go to their GP and demand a different form of care planning? What would the health service, how would the health service deal with that? Because that's what happens in other industries. Consumers demand the new. Now, I think in health systems, we've been frightened of patients because we've generally seen them as in some way conservative because they want to keep their local hospital open and they're always campaigning against the things that we know are best for them. Actually, I think there's some very interesting things to be had in this. So one of the systemic changes is how do we enable customers, patients in every other industry will be pulling this through. This is about us as payers, and I don't think you need to, because you've not got a commissioning system. But the last point is a quote from the national organisation that's now running the health service, like Alberta Health Services, actually has created an objective for the whole of the health service, which is about, it's very interesting because governments don't use words like this, dramatically better involving patients in their healthcare. So there is a bit of leadership at the top, as well as attempts at changing throughout. These are, I'll go through these in some speed, these are the different forms of change that are necessary, the nature of the consultation that takes place between the doctor and the patient. If I am to be seduced to go back and ever see my doctor about my rheumatism, the only way that's going to work is if they treat me differently at the beginning of that interaction. If they say, what sort of exercise are you doing, how's it going, rather than actually take control of that, which they do at the moment. Crucial thing is, more than medicine, we know that healthcare, we know that long-term conditions are both clinical and social. We know that social isolation for long-term conditions is actually a really bad thing. Not just with long-term conditions. If you have a heart attack, it's very important to have some friends and family. If you don't have friends and family, the likelihood of you having a second heart attack goes up enormously. Social isolation sort of kills. And therefore, we need to do something about social isolation that isn't clinical. And more than medicine is simply saying we've got examples in here where doctors prescribe walking groups, because that's pretty essential, right? As essential as the drugs you don't take. So it's how you get more than medicine into medicine. How you then have peer groups. We have a long-term theme of expert patients in England, and you know, if I'm very sorry you've got diabetes, go and talk to Fred. He's had it for 10 years, and you can spend an hour with Fred, and Fred will tell you what it's really like, rather than the 3 minutes you've got with me. And the doctor needs to literally give that relationship to someone who has a different relationship with it. And that is another asset combining with my asset to actually add value to the system. What you've got in your society, what we've got in our society is a whole range of networks within civil society that actually are out there doing this. One of the things that the NHS immediately start to give it this problem, it says, right, we'll set up walking groups. No, there are walking groups out there. You know, doctor-led walking groups are not as good as people-led walking groups, right? You do not need to do this. It's happening, right? What you need to do is know it's there and make sure that that's there as a part of your assets, and that there is an analysis that your local health service says of all these potential assets that you are prescribing people to. So this is just the next set of slides goes through what I've just said in more detail, and these are just the references for the Nestle. These are fiendishly long URLs, which is why don't try and take them down, you'll get them wrong, but they'll be given out. And the last is the crucial thing about patient organisations arguing for this quite passionately, both at a system level and at a local level. Thank you very much.
So, Paul, how much of this is a really new thing, and how much of it is recognizing things that are already happening? And one example is patient education. I recall a study that found that surgery rates, I think prostatectomy, dropped dramatically when patients were given a proper view of benefits and risks. So, for example, patient education, how much of that would count as this, and how much is that what we should be? Well,
interestingly, we've developed a number of things called patient decision-making tools, which again, the proportion of doctors that are using these, probably only 5 to 10%, right? But actually, specifically around prostate, it is actually you go through with the doctor and the patient what the choices are, and what the sorts of odds are, and you're part of that decision-making tool. And you don't sign the thing off in the end unless you sign it off. So I actually think where you're right is that medicine has been involved in a bit of this for quite some time. But it has been seen, and the reason I'm making as strong as an economic case as I can, is that economic cases drive these little things into the heart of change. And that's why I think my responsibility is to actually ensure the economics of this works as powerfully as, if you like, the morality. I think the morality of patient education, the case has been made. I think the efficacy of patient education for adding to healthcare outcomes has been made. But actually people say it'll cost. So you need to find a way of demonstrating what this new economics might be, where we're changing the value equation, and how every piece of education, providing I learn something of that education, is adding to my capacity to do self-management.
My name is Tricia Sizikowski, and I'm with the Alberta Health Industry Association. Our mandate is to build the health industry, and that we define the health industry as care delivery, business, and research, working together to improve healthcare. I'm wondering about the process of how to make this change, this people-powered change. What, in your experience, is it the administration? Is it the physicians? Is it the patient? Who starts this process? Who is the I guess, the beginning of this?
I think, and I think the interesting thing in relationship to the previous question, the beginning is a recognition that some of this is going on, rather than actually it's completely new and invented today, right? Because that's much harder to say the second. Then for me, it usually consists of a passionate clinician or some passionate patients. It usually consists of somebody in a patient group that's heard about it happening somewhere else, has actually thought, well, I quite like some of that. How do I get this? How do I get this, right? And then the patient organisation, especially if it's a well-mobilised one as Macmillan's or Diabetes UK, will actually say, well, try and going and asking for this. They will have some, inside all these patient groups, some passionate experts, clinical experts in that area. But I think you'll need, I think the real answer to your question is you need some people at this stage who are inside the system to argue for that change. And that's why I say clinicians and patients, they are inside the system. You then need some enablers. You need some enablers who will then say, fine, we'll change the nature of pricing. So I spend a lot of my time going around doing very boring enabling sorts of things to actually say, God, we can't do this because the pricing won't. Well, let's change the method of pricing. And that's an enabling mechanism. But I think, and equally, in terms of your own activity, one of the problems that industry has had in the past with healthcare, and the way in which you framed your mission statement, I think demonstrates to me you moved on from that, is that actually industry was selling gizmos that were answers. And actually they weren't, they were gizmos. The answers are if they're part of a pathway. So a piece of technology which can link a home to a healthcare professional is potentially a thing that's making the home a better location for high acute care, but only if it fits in with that wider set of relationships and not a thing in itself. And so the way in which I think industry will play a very strong role in this by posing its innovations as a part of a pathway which will encourage the capacity of patients to better self-manage.
Thank you. Hello, great presentation. Thank you for coming here. My name is Cristina Popescu. I'm a project manager with the Canadian Patient Safety Institute, where we have a network of patients and family members who work together with the healthcare system to make it better. So in response maybe to my colleague's question, there are changes happening locally. We know healthcare organizations have advisory groups. Our patient network is working with health organization at the Canadian level to represent the patient voice in policy making and decision making, and right at the beginning of the food chain. My question to you is, what are the indicators of success when it comes to patient engagement? And if you can refer to system level indicators, because from what I know, we're higher up in the systems, we work in offices, rather than at the front line, I would appreciate learning more about that. Yeah. Thank you for the presentation.
Okay. I'll start with the front line, but I'll build up from that. I mean, the Americans have a very interesting score called a patient activation measure. So at the end of a year, at the end of the year, my doctor could be judged on whether I'm more active in my healthcare, not just in terms of exercise, but more active, a participant. We could then scale that to a national system level. We as a system, and I think probably you as a system, need patients to be more active in looking after themselves. And so we could scale up the proportion of activities. Let me, a concrete example of how this worked in a particular area of England. I had a session with a whole bunch of old people's groups about what they would see as a good outcome. And they said at the end of this, look, you spend a lot of money on us, and we do. It's probably about a third of the health service money is spent on 1% of the population. Most of those are old. And what we would like at the end of that is the end of every interaction. This is so sweet and so difficult. At the end of every interaction, we would like to be more independent than we were at the beginning of the interaction. That's a neat idea. Not a bad thing to want. Completely the reverse of what we do. Right? So in discussion with these old people, they said that's what we want. And of course, the people running the hospital there said that's going to be really difficult. So then the old people said, let me get this straight. You actually pay people to do things at the moment to make us worse. No, you don't. Yes, we do. No, you don't. Don't be stupid. You don't do that. No, you do. Right? So that actually you go into hospital a little bit demented. You come out very demented. And we pay you for that. Yeah, you do. No, you don't. Right? And honestly, it is so in a sense, scaling that up, I would say, how does health add to independence? And that's a social outcome as well as a health outcome. Because I think most of us would agree that most state expenditure we should be thinking about that as an outcome. And actually, certainly in my history of my own society, most state expenditures constructed dependency. And that's led us to an enormous set of problems. And health has been a part of that. So, if I was to construct a real set of outcomes for results-based budgeting, it would be, what is the nature of independence that we're striving towards with this health money? And actually, that's going to be very hard. And I'm just working with people on dementia the other day. Again, we tend to see dementia as just managing decline. Now, actually, it's going to be very tough, but actually, there can be some growth in that. Intellectually, we think there can be some growth in it. Well, why don't we systemically incentivize that growth, right? Rather than actually just assuming. So for the great mass of 15 million people with long-term conditions, the patient activation measure and the fact that the real truth is, if in 5 years' time my rheumatism is on top of me, I'm going to be miserable. If I'm on top of my rheumatism, I'm not going to be miserable. Right? And that is my activation. Right? And I think that comes to a societal level as well as at a personal level. And it's just your point about, just make your point about patients. It seems to be the interesting thing that modern patient groups have the opportunity to do on an issue like safety is not just go to the docs and say, you've got to do this, but to say, we can do this. We can do this to add to the prospect of safety. We can be a part of that process because we have the capacity to add to this rather than just to receive.
Hi, thank you for your presentation. It was fascinating. My name is Esther Steves, and I'm a consultant. And I just wondered, a lot of what you focused on deals with system-driven change and the need for the larger players that are currently in the system to play a leadership role in facilitating the change that needs to happen. But I'm just wondering if you've studied at all the role of sort of more grassroots, disruptive innovations in driving the change.
Yeah. This is, and to be frank, I'm not suggesting an alternative to social movements here. I don't think, and I was trying to be, I don't think the old system's going to be the organisation that brings in the new. I think the new system's going to be the organisation that brings in the new, and the old will resist it. So, in terms of the leadership of various parts of the National Health Service, I go around trying to find people in a sort of subversive way, but actually that phrase that we want to dramatically improve, they're not doing very much because actually they don't know how to do it because their model that they work in doesn't play with that. So in terms of what I think I've been describing is a social movement theory of change, which actually depends upon the patient organisations. There can be leadership doctors. I'm not, but actually this will be driven by people pulling this change into the system around a set of expectations that I will not be treated like this anymore. And I think that phrase is in lots of the rest of people's life, but not in health services yet. Although I'm suggesting with this Richmond group is getting there. So I'm not saying this is totally insurgent, because actually a lot of the old system will be there in the new, but it needs some grassroots oomph, because it's describing a new business model, and all the studies of new versus old business models demonstrate that the old finds it very difficult at this moment to actually sponsor the new.
Paul, we're almost at time, but I'll just ask one more question on behalf of clinicians. We've talked about patients and the public. It's hard to get working clinicians to events like this, but there are people here from the strategic clinical networks, and I think a question for them might be, how do we incentivize clinicians or make the choice real for them? I mean, right now, they're prescribing everything they have time to prescribe. We're maxing out the payment system. So how do we get clinicians to actually prescribe the kinds of things you're talking about?
I think a part of that has to be changing payment systems. I don't think it's the total thing, but I think a part of it. I think those payment systems are incentivizing activity that will bankrupt our systems. And if there was any other system doing that, then people would say, my God, we've got to change that. So I think a part of that is that. I think another part of the discussion with clinicians is that some clinicians really get this, what I'm talking about. And the reason, again, I bring up the anaesthetist is I just find that a riveting example, as it is with maternity, as it is with almost every leadership group of every group of clinicians contains some people that say we need to do this differently, and they recognise that actually certainly family doctors in England refer to their experience of their practice at the moment. They use analogies which are drowning analogies. These are truly awful. There is a tsunami of need coming towards us. I'm being flooded by people with long-term conditions. Now, drowning analogies are unpleasant, right? And so describing how you can not be drowned is quite a good discourse. And so I think clinicians, there is a discourse to be having. And if you would allow me to play a bit more role in what I'm doing here, then perhaps I could clinch my long-term condition rather than coming back and seeing you every 2 weeks and do something with it. So I think you're dead right. We do need a discourse. We need a narrative with clinicians. But I think the payment system that we have had, and I helped to construct, which is a payment by activity system, the year of care and all the things I'm talking about need to be a new form of payment system which incentivizes different behavior.
On behalf of AIHS and IHE, thank you, Paul. That was just a terrific talk. Thanks very much.